Today we speak about blue lesions. Blue color is a fascinating dermoscopic finding that can be seen in a variety of benign and malignant pigmented lesions of the skin. This is a stereotypical example of blue color that can be seen dermoscopically in a beautiful tattoo. Colors in dermoscopy depend on the level where the pigment is located within the skin. For example, black corresponds to a pigmented conified layer, whereas blue color corresponds to pigmented structures located within the dermis. Unfortunately, blue color is a highly unspecific finding, as it can be found in many different lesions. Thus, important is what we find around. Blue lesions can also be difficult for the pathologist, as is the case here. A blue lesion revealing histopathologically only melanophages, which do not allow final reliable diagnosis. Blue color can be the predominant dermoscopic feature of the following melanocytic and non-melanocytic benign and malignant tumors: blue nevus, Spitz nevus, melanoma, basal cell carcinoma, vascular lesions, seborrheic keratosis, and other types of non-melanocytic tumors as dermatofibroma, adnexal lesions, and so on. This is a seborrheic keratosis with striking blue color. The correct diagnosis is just made possible by the presence of clear-cut comedo-like openings as outlined by the arrows. These are 4 examples of hemangiomas and angiokeratomas with evident blue color, and the correct diagnosis is facilitated by the recognition of sharply demarcated red-bluish to black clots, also known as lacunes. Please see the arrows. This is instead a basal cell carcinoma with predominant blue color. The correct diagnosis in this case is made possible by the presence of arborizing vessels, look at the arrow, and multiple erosions within the circle. This is a melanoma with predominant blue color, and the high index of suspicion is achieved just because of the presence of pigment network and irregular black dots and blotches. See the arrow. This is a pigmented Spitz nevus with central blue color, but only the presence of peripheral streaks allows its correct recognition. Blue nevus is the only lesion in which blue color is the only detectable feature in dermoscopy. In blue nevi, the blue color correlates histopathologically to large amount of melanin within the dermis. And often in blue nevi, white areas can often be seen correlated histopathologically to dermal fibrosis. This is another example of blue nevus with white and blue structureless color in the absence of any other specific feature. Especially in fast-growing pigmented melanomas, blue color is usually prominent, but the classic melanoma-specific criteria might be lacking. In these instances, the blue-black rule can be a useful clue to raise our index of suspicion. For example, this is a fast-growing melanoma only revealing a combination of blue and black color dermoscopically. And this is another example of nodular melanoma exhibiting striking blue and black color in the absence of any other melanoma-specific criterion. Another example, a fast-growing melanoma with blue and black color. And again, another fast-growing nodular melanoma with blue and black color. The only 2 exceptions to the blue-black rule are lesions presenting with black lacunes or black comedo-like openings. In these cases, despite a positive blue-black rule, the lesion can be regarded as benign, as you can see here in 2 examples of angiokeratoma and seborrheic keratosis. Using the blue-black rule, only 7% of negative lesions are found to be melanoma, and only 9% of positive lesions are found to be benign. So the rule is quite reliable and efficient. So in summary, blue color is a highly unspecific dermoscopic feature, and the diagnosis is facilitated by the presence of specific features found together with the blue color. Blue lesions, additionally revealing black color, should be managed with caution, and, as a general rule, a biopsy should be performed of any blue lesion that cannot be clearly diagnosed as a blue nevus, as an hemangioma, or as a seborrheic keratosis. Bye-bye.